Thanks again so much. And for many of you in the audience, you were at Gerontological Society of America all last week, so this is quite the marathon, and it's a busy week with Thanksgiving. We're really happy that you're here, and what an interdisciplinary crowd in terms of who was registered. And it's going to take all hands on deck to come up with really strong ideas for this next phase in our society, so we appreciate your time and your focus. Here's an overview of what we'll be talking about for the next half hour. It looks linear because there's numbers attached to it, but it's not very linear. It's more just laying the groundwork, setting a framework for the day. So we'll go over a few geriatric principles first, just in case some people haven't thought about this space before, talking about the heterogeneity of aging, the third demographic dividend, function, its importance, and the role of the environment in disability. Then we'll move on to just the simple categorization of a few tech buckets and how they apply in terms of the three aging stakeholder groups we've talked about for today, with the older adults, their care partners, and the health system. And then a strengths-based way of looking at approaching these. And a subset of that is this value shift in healthcare that we're undergoing at the same time as we're undergoing this demographic shift. And then we'll have plenty of time for questions and discussion. So we'll start with a few people to ground us as we start the day. And this is to underscore the heterogeneity of aging, to make sure we don't design just for our own mother or our own grandparents. So if someone told me they have a 2-year-old, and I can pretty easily say, oh, they're probably saying no a lot right now, right? That developmentally 2-year-olds are fairly similar unless they have some kind of genetic problem where they were born with a difference. 3 2-year-olds are probably each, they're walking, they're probably running, they're probably saying no a lot, they want some time away from their parents, but they really need their parents back. You can know that without having met them, right? But 3 different 80-year-olds, one might be a marathon runner, one might be in a wheelchair, and one might be somewhere in between with a few chronic conditions and some functional limitations. And you can't know an 80-year-old before you've met them. And this is important for us because in terms of the stereotypes of aging, often we're thinking about someone who's hobbled over. You know, if you look at the media images, if you Google old person, you know, a lot of times they're a grandmother with a bun on the head and with a cane. And so it's our job as part of today to think about that whole spectrum. So I'll just give you a few examples just in case it helps you as you're thinking about cases. So this is Mr. Kennedy, and he is a World War II veteran. He's in a lot of pain. He's on dialysis, which means his kidneys have failed, and so he's got a machine that filters his blood for him. He gets picked up by a mobility van for the dialysis, but other than that, he doesn't leave his house because it's very difficult for him to do. He's depressed, but he does not use that word. He's got a flat affect, as you can see, and the main thing that he would like to do would be able to sit on his back stoop and listen to the birds in the backyard, but he can't get out there himself because he wheelchairs around his apartment or his house, and he can't get out the back door. In contrast, this is Betty Soskin. Some of you may have read about her. She's a 97-year-old, and she's a park ranger. And she's had a long history of being involved in civil rights and community activities. And you can see she's ramrod straight. She has almost no physical limitations. And she's 32 years older than 65. And then as a third, these are the Johnsons. They get along well. Mrs. Johnson has high blood pressure and arthritis, but not much symptoms from them. Mr. Johnson has congestive heart failure, had a recent hospitalization. He's eating his kale, you can see. They both volunteer and are involved in the community, and they have foster grandchildren, but they do have some aches and pains and functional limitations. So try to keep that whole range in your mind as we think about the solutions and the issues. All right, so the second sort of geriatric principle I wanted to introduce is this idea of the demographic dividend. So there's a wonderful paper by Linda Fried in 2016 that this comes from, talking about how the first demographic dividend was as we, in the developed countries, as we were able to pretty much guarantee that children survive infancy. This was a huge change, as we know. And then the second one was that those children lived into adulthood, and they were able to contribute to society and contribute to the economy, and that was a huge dividend that was from public health measures, but impacted the whole economy. And we're just on the verge of the third one now, which is, think of Betty Soskin. She's been alive 32 years after 65. That's not just a phase of life. That's like, several phases of life. If you think about 32 years before 65 is 33, right? Think the difference between 33 and 65. That may be several jobs, that may be children and a new career, or, so if people are healthy and engaged, there's such an opportunity to harness that period of time. And in fact, Johns Hopkins is well known for work and experience core that was partially developed here, where older adults volunteer in elementary schools. And that's a win for the schools, for the kids, and for the older adults. The older adults' roles are designed on purpose to be cognitively active and physically active, and socially engaged, of course. And so there's strong evidence that has helped with their cognition. And if you can picture the short seats and the short toilet seats in elementary school buildings, just getting up and down from the seats alone is kind of a physical activity engagement. So I use that as an example, but there's many other ways we can think about enhanced roles for older adults in this third demographic dividend. And as we frame the day, we're not just talking about ways of managing disease or ways of managing functional limitation. We're talking about the whole kebab, the whole thing. What are the opportunities? What are the chances? What can we do, as well as what are we going to do about health care? So just a few words about function. Physical function is what we tend to care about a lot as ourselves, right? Can we get out of the bed? Can we do what we want to be able to do? But I bring up this slide. It's old data, but the data are always the same, that you're much more likely to be what economists call a top healthcare spender or a high care utilizer if you have functional limitations on top of your chronic conditions. So the blue line is the relative probability for the general population of being a high-cost user. And then as the numbers march up as people have difficulty with some kind of self-care, like bathing or dressing. And so function matters to people, it also matters to society if we're going to keep from having our dollars completely absorbed in caring for the older adults. So a few moments about disability and modification. So if you look at this, you can see the y-axis is function and the x-axis is age. And this picture is doing a few things. On the left side, where it says early life, you can see the divergence of the orange line and the blue line. The point of that is showing you that to have older adults not suffer from disability, it's important in their early years to be as preventive as possible, to get that line as high up as possible. So for example, let's take cognition. There's excellent evidence that the quality and density of education that we have as young people is related to cognition later in life, right? So people who have higher education have better cognition later in life. And so that of the current cohort of older adults who maybe had rural childhoods or childhoods where there was discrimination and they didn't have as good access to education, they didn't get as much of that education power built into their brain in the early stage. And so that's a lost opportunity in terms of disability later. Same with, let's say, osteoporosis. We know that we're all building bones until we're 20, 30, and then we do our best to keep our bones up. But the more we can be improving, calcium and exercise in young adulthood, the more we can be on that orange curve instead of the blue curve, right? So that's the first point of this slide. The other point is that in the older life, you can see the span between the orange and the blue shows you the heterogeneity we're talking about. Someone can be the same age, but they have a very different functional ability. And then the third point of this is that if one's considered disabled has a lot to do with the environment that one's in. So if you think about some older adults you know, if they have a 20 steps down to get to the street to leave their house, they may not leave as much as if they have no steps or 1 or 2 steps. And that's just a difference in the one aspect of their environment. And environmental changes can be very simple. Here's just an example of 2 80-year-olds live in that house, and really no one should ever live without any banisters. But just putting up 2 banisters can make it, that could be the difference between being disabled in terms of stairs than not. So sometimes very simple changes can make a big difference. So we'll switch now to what I was saying about the 3 tech buckets, and this is rough, and people disagree about these categories, but it's just something for us to be able to frame out what we're talking about. So if you think about sensors and wearables as one category, big data as another, and robots, apps, and things as a third, we'll then apply that to our 3 populations. And this, I don't know if you all have seen before, one of these seals that's in some nursing homes for people who are really cognitively impaired. They apparently can give, at least anecdotally, some sense of companionship. So if you take the older adults, the caregivers, and the health systems, and you put them across those 3 categories that, again, are muddy, but we're going to use them this morning, you can imagine, so for example, a robot in the upper right-hand corner, a robot for an older adult would be different than a robot for the health system, right? So the robot for the health system here is picking up a patient, which I understand we're not so good at yet. But you could imagine that could be a way of decreasing injuries of staff in hospitals if we could have a robot that did that. Whereas a robot with an older adult might be doing very different things, might be more companion or answering questions. And similarly, sensors in the caregiver space might be, a wanderer alert, is someone leaving the space that they weren't supposed to, whereas a sensor or a wearable for an older adult, might be an Apple Watch or a Fitbit. So the idea of this was just to help us think across the populations and across the tech kind of challenges. All right, so bear with me. This is a little bit of a leap, but if you think about psychology until about 30 years ago, it was all focused on negative things, right? Not all, but mostly. So psychologists and psychiatrists studied things like depression, anxiety, schizophrenia. And Viktor Frankl, after World War II, developed logotherapy, which had to do with meaning and meaning in one's life. And he did this based on the knowledge that for people in concentration camps, and he was one of them, survived if they were living for something, and specifically if they were helping someone else in the concentration camps. And if you haven't read Man's Search for Meaning, I highly recommend it. It's very short. And then Seligman at Penn developed it further and talked about the pleasant life, the good life, and the meaningful life. And I'll tell you how this relates to what we're talking about. Just as a semi-aside, people often talk about Maslow. So here's a diagram of Maslow's hierarchy of needs. And in Maslow, who came after Frankl and before Seligman, you had to master your physiologic needs first, which is obvious, right? You need to be able to breathe, you need to be able to have your kidneys work and everything before you can think about self-actualization. But where I think Maslow got it wrong, and where Frankl and Seligman essentially have it right, is that you shouldn't have to wait until everything else is taken care of to be finding meaning in your life, right? That shouldn't be just for the super special who've got everything taken care of. That should be a basis of what we're about. And so, going back to these categories, we're going to apply them to our populations, but I'll just tell you a little bit more about what they are in case you don't know. So the pleasant life, the idea is, yes, your physiologic needs are met, and you have enough money, and you are able to take care of yourself. And on top of that, you do things for fun. You can get ice cream if you want to. You can go to a movie if you want to. That's pleasant, right? But that's not enough for most people to feel like life is engaging. The good life is if you've got all of that, plus you are using your signature strengths in ways that also they fulfill you. So let's say in Mrs. Johnson, who was one of the characters from the beginning, let's say she really likes to garden. And she feels literally grounded when she's gardening, and she loses sense of time, and she plans out the plots, and she's excited, and that's a good life on top of the pleasant life. The meaningful life is all those things, plus when you're using those signature strengths for a new purpose that is helping others. So, for example, if she did her gardening and she made a community garden and she was teaching young people how to garden, then that is the meaningful life on top of it. So I know this might seem like a segue, but I bring it up because all three of these stakeholder groups, populations, need these three categories, right? So we need that older adults can pay for the heat and can get to their bathroom and can get outside to do meaningful things. We also need that, right, so that's across the spectrum for them. For caregivers, of course, as well. And that there's, caregiving is both burdensome and meaningful, depending on all kinds of aspects. And that we can't just rely on caregivers as a population and not provide them with ways of being able to have that full spectrum all the way to the meaningful life. And it's for the health system, right, it needs to be able to pay its bills and get people in the door and prevent things, but also, again, to use their signature strengths in new ways, right? This is what we're doing here. We're a group of very smart people with all slightly different backgrounds. Let's gather our signature strengths and try to use them to change how we think through these issues as a society. Just to pull us back to reality again, just a reminder that although a lot of wealth is concentrated in a very few older adults' hands, in general, there's not a whole lot of extra money for your average older adult, and that 30% of older adults live on less than $23,000 a year. So if you think about that, the apps better be pretty cheap, the robots better be pretty cheap, unless we're financing things in a different way. And just talking a minute about not just the demographic changes and societal changes, but also the healthcare shift. And again, for some of you, you know this completely, but some of you may not have thought about this. So this is a perfect time to change the way we're thinking, because there's a big shift in how we pay for healthcare. So it used to be, let's say if you're a hospital, you needed people to have heart attacks, and you needed people to have very low birth weight babies, and you needed hip replacements, because that's how you paid the bills. And as it's shifting to where what you actually need is for the population to be healthy, what that means is that you don't just pay for a widget. You don't just pay for this drug or that stent and make money off of that. You can think much more creatively. How can I help Mrs. Johnson stay healthy and able to take care of her foster grandchildren? How can I help Mr. Kennedy be able to get onto his back stoop or get out to an event that he cares about? Maybe that's giving them Meals on Wheels. Maybe that's giving them a robot. Maybe that's if you already know the budget ahead of time, and it's inclusive of whether people are staying in a hospital or not, and you're desperately trying to keep them healthy out, then it's just a whole clear slate in terms of what you can pay for. And so this matters because I think Michelle Carlson's going to present a little later about Bandit the Dolphin, who was developed by the Kata Lab here, and also she's adapted it. But they're doing work that combines cognitive and physical activity, where you're making this dolphin swim, and making it do things by your movements. And so you're getting exercise and you're cognitively enriched at the same time. If you, in the old days, if you were, let's say, a hospital and you thought that might prevent a hospitalization, you might try to bury something like that. But now maybe you'd want to buy it, right? Maybe you want to say, okay, everyone who's at risk for this can have access to Bandit the dolphin. And so our substrate for what the sort of test bed is completely different. We don't just have to just think about, pills and procedures the way we may have 20 years ago. So what does this mean for you and the audience? You each are from slightly different backgrounds with different interests. Some of you may have pet projects. Some of you are here just to think more broadly. But it's just some questions about which, are you more from the health system? Are you more from a caregiver side? Are you an older adult? Maybe you're all three. And what needs do you wish to address? Do we already have the technology and we're talking about adapting it? Or is it something that's completely blue sky? What data do you need? What partners do you need? And now we're open for questions or discussion. Sir.
I'm Richard Spernow, and I have been chairman of the Central Maryland Easter Seals for a number of years. And we ran into the Easter Seals board, the main board that I was with had 20 of us. 4 of us had no relationship to Easter Seals at all. The 16 other people either had a family involved or somebody that Easter Seals had sued. So it's but a very, very industrious board. After some time, studies that were done, voluntary studies that were done, we came up with the conclusion that there's not enough staff to care for the aging population, combined especially with the juveniles or the younger generation. But we started to come up with some crazy numbers that if we were able to take the funds that we're able to get for the senior citizens, and we take the funds that we're able to get for the junior citizens and throw them into one bucket, all that we had to do was start retraining professional staff. So we'd have people who were trained to care for seniors and treat children. They had to do the same. And then the rest of our staff started to become dogs and babies. Okay, the adults just love puppies and dogs, and the other side loved it. And it just continually grew to a huge success. And now it's grown into wounded warrior families.
Oh.
Okay, and wounded warrior families, when it started, unfortunately, such as we get publicity that went on with people jumping in, raising money, sending stuff that goes on the phones. But the reality of it was we had a Lisa, I can't remember what last name at the moment. She arranged when it first started to have 10 wives of generals and from the military side and also from the military side admirals, the wives. She laid out this problem to them, and there was no money, but they all went home and got money from each of their senior government employees who had some room in their budgets, and they all put together, and that was the beginning of how it all happened. So you can make things happen, you can get a picture of what you want to do, and this is a great picture of what we need to do.
Great, thank you for that. Yeah, Dr. Bandy Roche.
That's great, Sarah.
Thank you.
So much. You have so much experience in the community, seeing people in their homes with various needs. If you could think of an engineering advancement that would help the people that you see, what would be your wish list? One or two.
Oh, I should have thought to plant that question, and I should have thought to come up with answers ahead of time. I showed the picture of the banisters on purpose because I think that there's a lot of low-tech that we have to be implemented as well, and that we shouldn't just think about high-tech. I have seen in my experience, just huge changes from someone being able to, stand up when they shave, and how the dignity that gives them, or bed risers that go under a bed so that they can stand up from the bed themselves rather than being pulled up. I think I might be the wrong person to answer that question, because I think that the low-tech should certainly be part of the solution, low-tech, and where people are trained and they know how to use it well. I think that social isolation is a really, really big problem, and we know that from evidence that it's about the same size or risk factor as smoking a pack of cigarettes a day in terms of cardiovascular impact of social isolation. And so for some of the likely tech advances coming down the pike, I'm hoping that will help, but we don't yet know whether social isolation, whether Skype and FaceTime and things like that are actually replace real in the same room physical contact. So there's a question over here, Bess.
Hi, Sarah Beth.
Hi.
Thanks for your terrific talk. I have a couple questions. One is, I really like your pleasant, meaningful life.
It's not mine, but yes.
I'm forgetting
Here.
the names of that. And in particular, for the good life, you talked about signature strengths.
Mhm.
That's really important for us to focus on. But what do we do around Alzheimer's or other types of neurocognitive degenerative diseases where those conditions rob someone of those key signature strengths and are just really grappling with the loss of those skills that made them a meaningful member of society, and that's really what their identity rests on. And have folks taken this framework and then said, what do we do when the signature strengths are taken away?
I think that's an excellent point, and I only put this together in the last 2 weeks, so I don't know that other people have done the same. But to answer your underlying point, there's really powerful work in dementia, and specifically using people's preserved interests and abilities to engage them in meaningful activity. So I'll give you an example. In the tailored activity program that was developed by Laura Gitlin and colleagues, they have, and the video of this is just astonishing. So they have video of an older gentleman who's in a nursing home, and he has dementia, and he's so distraught that he's following the staff around all the time, actually following them into supply closets. And in some settings, he would at that point be sedated because they can't do their jobs, and he's just on their, the back of their neck all the time. But using this tailored activity program, he had been an architect, and they knew that, and they did an assessment of what his preserved strengths were and interests, and they sat him down in the morning in a room and said, we're trying to figure out how we would change this room and where things should go. Do you mind drawing it for us? And he does it for the whole day, and he's completely engaged. He thinks he's helping them out, and he's redesigning it, and he'll do it day after day. And he doesn't remember the day before, but he's happy, it seems like, each day. And similar, for someone who has less preserved strengths in that same program, they've had where someone had been a fisher and loved their tackle box. You have to be careful that it's not dangerous, and rearranges the tackle box each day. And so in some ways that's sad, but if you're living completely in the moment, there's nothing sad about it if it's your interests and what your abilities are. So I think there's a lot of room in there to build on the strengths that are preserved up until death.
You mentioned a shift in the health system and moving from service to cover lives. How do we grapple with the tensions of, and I've heard it described as value-based care.
Mm-hmm.
I don't mean economics. What I mean is driven by the person's values and goals for what they want to achieve in life, as opposed to the optimal medical health and the optimal treatment, grappling with different, treatment, prescription medicines, and so on. How do we engage that dialogue or those set of compromises in this area? And it relates to end-of-life care, but it's not just.
Right. Well, so that's a big thorny issue for this early in the morning. There's a lot of work on, goals of care, and goals of care conversations have started off with palliation. Would you rather feel better in this next 6 months and die, or would you rather have the chemotherapy and feel ill, those kinds of things. But we are starting to see shifts to much earlier in the lifespan of what are your values? What matters to you? What are your goals? Not because you're about to die or you're about to have huge treatment, but how can we as a health system help keep you, sorry, I'm tripping over this tape. How can we help you have the most meaningful life possible? And yes, I talked about it as value in terms of cost, but implementing those kinds of conversations. I think we do it in some preventive session, in maternity care sometimes we talk about, and in pediatrics sometimes we do, about parenting, but that there's a big, there's a big venue to do it throughout all of life. And I think that the people would like going to the doctor or the nurse practitioner more if it wasn't just take your medication and why aren't you exercising? Yeah.
Okay, so we have a couple of mics. I would say if you want to ask a question, you're not land lost, just head out to the mic, otherwise I'll try to bring it. I had a question I wanted to ask you, sorry. When I started out, I was talking a little bit about some of the technology waves that we've all experienced in the last decade. And I'm wondering how that is playing itself out, both in the population of older adults, but also caregivers for older adults. Has anyone really looked at the technology demographics or tried to predict what the technology demographics are going to look like, just in terms of use of technology in daily life?
I think that might be a better question for the panel, as they've looked at that a little bit more. But what I've noticed is that the numbers are very different if you're talking about 65, 70 older versus 50 and older. So, because a lot of us in this room are probably 50 and older, right? So 50 and older, it's something like 90% of people use smartphones. But if you're talking about 65, 70 older, not as much. And so caregivers, as we're going to hear from a whole caregiver panel, but really span the age range as well. And so there is a lot of evidence, but I don't think we know that much about what we should be doing next in terms of tech for caregiving.
Hi, Charlie. School of Medicine. Just want a little framework. I'm just looking at care, always looking for what's missing. I just wonder if it's maybe relevant to the community.
Yes.
And then thinking about how technology support the community, et cetera.
I completely agree with it. Thank you. I set it up the way that the day is set up, but absolutely. I think community is essential and is a big feedback loop to all of those. Thank you I hope you'll put that on your aha moment, post it, and put it on the whiteboard. And sorry, we keep missing you.
Hi, John Gersh from the Hopkins Supply Physics Lab.
Hi.
Given the heterogeneity of aging that you've described, how do you think engineering for an aging society is different from engineering for a society in general of varied needs and abilities?
One might say it's not, right? I think that, that's a really important point. I guess I would say that we're going to have more people, we're heading into a time where there's going to be more, somebody help me out, more people over 65 than under 5. And that's not happened before. So that even though there's great heterogeneity, there are some inevitable changes, and that having the mix, it's more about the mix of the society in terms of numbers. That's going to be the big shift. So one of the geriatric classic pictures I didn't show is it used to be more of a pyramid in terms of age population where, there were a lot of children and then fewer middle-aged adults and then very few older adults. People have always lived to be 100. It's just been extremely rare. And now it's much more common. So it's a much more of a rectangle now in terms of the demographics. And so it's also that proportion that, there used to be something like 6 potential caregivers for any older adults, and we're heading into where there's going to be more like 1 or 2 for any older adult.
So the society that's aging.
Yes,
It's engineering for that society, not engineering for the aging.
exactly. Thank you. Can you write that down? Or can someone write that down? Hi.
Hi, Sarah.
Hi.
Frank Kotezak, we've met before, involved with the entrepreneur investing in aging tech. I was at the Aging 2.0 Optimized Conference in San Francisco last week. 3 kind of big enigmas that seem to everybody struggle with is things that people are working on, how to make sure that they work across all the necessary dimensions, clinically, technically, commercially. And people approach it with one expertise and they either don't have evidence it works or it's not scalable technically, or they haven't found somebody who's willing to pay for it. The other thing is reimbursement. Particularly if you're trying to get reimbursement from the healthcare system, you have to get that as law, like trials, CPT codes, FDA approval in some cases. That scares away a lot of people. And then the other thing is, as you mentioned, as we move more toward population health and paying for value rather than volume, a lot of what we're talking about really is services provided outside the hospital and clinic, addressing the social determinants of health, and that's, nobody's really willing to pay for that yet. And so these aren't really questions, but just, these were issues that came up in San Francisco last week, and everybody's trying to figure them out.
Well, thank you for the report from out west. I would say I don't have as much gloom and doom about people not paying for the population health and social determinants. Just in our own experience with our Capable program, it's now in 25 places in 12 states, and it's a handyman, a nurse, and an occupational therapist completely outside of the healthcare system. But healthcare systems that are interested in avoiding hospitalization have started to adopt it with their own upfront money, because the evidence is so strong that it averts hospitalization and delays nursing home admission. So I do think that there are some brave health systems that are showing others how to invest in social determinants and what's meaningful to older adults to test those new solutions. Yeah.
Hi, Ken Hepburn from Emory University.
Hi.
Well, I just wanted to address Gersh's point. I think one of the points of heterogeneity that engineers are going to have to address is great diversity, familiarity with and comfort with technology. So we have a program we're running now, online training system for caregivers, and in some cases people just put it on. In other cases we have doctoral students who have to hold their hand through the whole process, time after time. So I think there's big learning curves that might have to be addressed over time.
Absolutely. And I think also we have to not assume that if someone can do it once, they can do it again. We all use our own parents as examples. My own parents could use my chart, which is the electronic health chart here, for about 2 years, and then now it's way too hard for them, and they'll say, I don't know how anyone could ever use that. And so we can't just assume that once someone can start, that they can continue for a long time. Well, thank you for the wonderful discussion. Are we moving on to panel one?
We can move on to
Okay.
Thank you, sir.
Thank you. Thank you.